Dear learned audience, very good morning. I am Dr. Lipika De, FCPS trainee from Department of Pediatric Cardiology, Bangabandhu Sheikh Mujib Medical University. Welcome you all on today's scenario-based discussion regarding ASD with variable presentation. My first case scenario is 1-year male weighing 10 kg. Patient was asymptomatic, incidentally diagnosed as a case of congenital heart disease during OPD visit for acute watery diarrhea, and he came from a remote area. Pre-coding examinations revealed size and shape of the chest was normal, normally located apex beat. First and second heart sound was normal, without any splitting, and there is a short ejection systolic murmur. We did some investigation. ECG showing 12-lead ECG with normal standardization and calibration with sinus rhythm and normal axis. Chest X-ray AP view showing normal study. Echocardiography reveals subcostal four-chamber view and bicable view, short axis view, showing there is 2D gap in interatrial septum measuring 4 into 5 mm with left to right shunt without any chamber dilatation and normal PA pressure. Now we will move on our second case scenario. After then, we learn from our expert regarding management plan. Our next second case scenario is 1 and 5-year female weighing 10 kg complaining about history of repeated respiratory tract infection. Precordial examination reveals size and shape of the precordium was normal with normally located apex beat. First heart sound is normal. Second heart sound is wide and fixed beating with a ejection systolic murmur. In this case, ECG findings are 12-lead ECG with normal standardization and calibration, showing sinus rhythm, right axis deviation with incomplete RBB. Chest X-ray AP view showing situs solitus, levocardia, centrally placed trachea with increased vascularity in both lung fields, that is, plethoric lung field and pulmonary conus with full without any cardiomegaly. Echocardiography in subcostal four-chamber view, bicable view, and short axis view revealed 2D gap, that is in interatrial septum, measuring about 10 into 13 mm, shunting left to right with dilated RARV and mild pulmonary hypertension. Now, we will learn from our expert regarding management of this case.
Sorry. I am Dr. Naruma, and we are going to start a very impressive discussion. And in the morning, we will start from a very simple case, and we will go through a complex till last. And first case, we have seen that 1-year male changer asymptomatic. My question is first, Professor Salam sir, that he came from a remote area, asymptomatic, 1 year. And we know that these small kids, those who have small ASD, those who are coming from remote area, they are very social cumbersome. There are very limited research person and very few pediatric cardiologists. So what will be your advice for follow-up protocol? Follow-up.
Actually, this standard protocol for closure of ASD we know there should be a right-sided volume overload, and the patient should be symptomatic. And but in this case, the patient age is less than 1 year and 10 kilo. But if there is actually FDA recommendation for ASD device closure or surgical closure is 3 years old and 15 kilo weight. But in case of clinical deterioration like that of the failure to thrive and repeated respiratory tract infection, and patient, if the patient is symptomatic, not growing well, you can have this patient you can close it either by catheter intervention, which is suitable here, I think. Yes, in this case, I will follow up every 3 to 6 months and symptomatic management and without a little bit of diuretics. And if there is associated problem like that of respiratory infection, we'll treat accordingly and we'll counsel the patient. Then we should follow up it because the shunt is significant, and so we'll move on to follow up.
Professor Krishna Kumar is here, but what I told in the case of first case, if this is a small VHD, if ECG is normal, ECG is normal, there is no volume overload, I think no need of treatment is here. Just follow up. You can say 6 months, even 1 month, because this is a small VHD. This is HD, likely to be spontaneous closure of this kind of a small VHD later on. So I think nothing is needed here, only just follow. Thank you.
So my concern was he came from a remote area,
No,
not
yeah.
always possible.
No.
So can we build by a pediatrician or cardiologist where the pediatric cardiologist is not available?
Not available. This
Not
is
always possible to come in Dhaka.
this is not. This is a small ASD. This is a small ASD. Whether it is in the Dhaka city or is the remotest area, that does not matter. Matter is whether he needs treatment, whether he needs intervention or surgery. As 1 year is a small ASD, nothing is needed. We shall only advise him just for follow-up. Even I can tell him to come after 1 year.
Yes. Thank you, sir. Coming to Madam. Madam, do you offer any medicine to this type of scenario? And sometimes in the OPD, we have found that this patient come with dyselectrolytemia for getting the medicine. So what is your comment?
Thank you, Sumaira. In our everyday practice, we encounter this kind of patient with small VSD getting diuretics. Even some of the patients, we see that they are getting AC inhibitors as well. So first of all, we need to know the natural history of the ASD as well as the indications of using drugs. So in natural history of the ASD secondum, I am not mentioning about the primum or the sinus venosus, which are not for actually closer in the which will not close in the natural history. But for the secondum ASD, in our experience, we have seen then that up to 2 years of age, there is good chance of spontaneous closure. So if we can allow this patient to wait for some time, they will close spontaneously in most of the cases, especially those who are less than 5 millimeter, even less than 8 millimeter. They have chance of closure. So this is the natural history. Keeping this in mind, now we can think about the medicine. Now medicine in ASD is for congestive heart failure or to reduce the right ventricular volume overload. So if there is volume overload, if there is chance of heart failure, in X-ray, if there is congestion in the lungs, there is too much plethoric, even we can calculate the QPQS from our software in the echo machine. So if we see that QPQS is high, RV is volume overloaded, in chest X-ray, lung fields are plethoric, in those cases we can use. But without any volume overload, we should not use. And if the patient are in the remote area, if we give them diuretics and they develop diarrhea, in those cases, every day 1 or 2 patients come to our OPD clinic with cachexia because of getting this kind of diuretics. So if we give diuretics in a person who is not indicated will be more harmful than not giving anything. Thank you.
Thank you, madam. So we have learned that this patient should be followed up. We can give follow-up 1 year or no medication is needed. But a very burning question is next to that, we frequently get in our OPD that some cleft lip, cleft palate, any other surgery or circumcision, this type of patient are going on. And they come to us that our surgeon are not willing to do the surgery because he has a hole. They don't mention small hole, but they are very afraid of this hole. So who should, what would be the advice, Professor Jahid Ahmed?
Actually, usually pediatric surgeon, when they do any kind of surgery, they usually refer to the pediatric cardiologist regarding if they find even a small PFO, they feel somewhat frightened to undergo operation. Instead, we write that there is no contraindication or there is no harm in doing the operation in this case because patient is asymptomatic. This kind of, even how can we do the intervention? Large congenital heart defect, we do cardiac catheterization, we do the intervention, we under sedation or anesthesia. So this is small with this small HD, the surgeon can undergo operation, but we usually write them with cardiac monitoring. But even if this is not essential, but in case of any operation, there should be with cardiac monitoring that I usually write when they ask for the opinion. Thank you.
Thank you, sir. Coming to KK, sir. Sir, your comment on the first one, asymptomatic child with small ASD. And my question to you, first of all, your comment, and then you are running a very successful pediatric cardiac program there in collaboration with the local pediatricians. Also, they incorporate in your referral system. So we want to know from you that how can you start this a good referral system that the pediatrician will send the patients timely and accordingly?
So the first case is a
Child?
asymptomatic child with a normal ECG, a normally split second heart sound, no RV volume overload, and a 4 mm ASD. I would reassure the parents first. I would spend some time and telling them that there is, as madam has said, a very high likelihood of this becoming very small. And I would tell the parent, even if it doesn't fully close, it perhaps doesn't matter. No question of diuretic, absolutely. I would not even give diuretic to the second patient. I think we have to be, the point that you made about using diuretic, it's overused. ACE inhibitors, very few circumstances merit ACE inhibitors in children. I don't think you need to give it for most of these situations at all. So I would reassure. I would write a letter to the pediatrician saying that this is a very small defect. The child is at no incremental risk for general anesthesia, can undergo any non-cardiac surgical procedure, and I'll give that letter. So that stays with the patient, and that patient can be used for guiding general anesthesia for these purposes. Follow-up frequency doesn't have to be more than once a year. This is a very normal child. A lot of reassurance to the parents is important because that way the parental anxiety comes down and you're able to take care of that. A referral system actually depends on networking, education of the pediatricians, writing letters, communicating frequently. And once you do that over a period of time, they develop the whole understanding of what you're trying to say. Invariably, we communicate. So we have such a patient, we either write a letter or we talk to them and say that you can just follow these patients. Correct. Here you don't need any prophylaxis, obviously. So that also can be mentioned. The child needs really no prophylaxis at all.
Can we write the pediatrician or cardiologist as well that when to refer a pediatric cardiologist in this asymptomatic group?
So this particular patient, you just have to require once a follow-up, but don't have to tell them when to refer because then they will refer. You don't need to. Here, this is where you can be pretty sure nothing. You don't have to be worried about the cardiac status at all. You echo 1,000 children of the age of 1 year. You will find at least 40 or 50 like this. You can't be looking after all of them.
Yeah. Thank you, sir. Now, coming to the second case.
And I will request our IT person to give the timer because we have 10 minutes for discussion so that we can understand when to move on the next.
So the second case, the second case was symptomatic child, 1 year, 6 months, weight 8 kg, dilated RARV, mild pH 11 kg, mild pH with adequate rims. Coming to KK sir, all the LUs are there. What will you do? Symptomatic patient, you will close or wait, or if close, why, or if not, why?
So a 1.5-year-old child, I would close if there is clear indication, in the sense that patient is failing to thrive and has
1 year, 11 kg.
1 year, 11 kg.
1.5 year.
1.5 year, 11 kg means the child is gaining a good weight. So I'm not worried about this child. I will not rush to ASD closure in this patient. I will also not give diuretic. I will just reassure the parents, but tell them that, listen, this baby is going to require closure. This ASD will not close. So close follow-up as per recommendation that was listed out by Sir, that at around 3 years of age, if the defect is reasonably suitable, which looks like it will be suitable for transcatheter closure, I would opt for transcatheter closure. Now, there are people who would close it even at 1.5 years in the cath lab. Now, the only problem with that is that it has been shown that the incidence of complications after a ASD device closure is substantially higher in the very young children. So you can have heart blocks particularly because the device will rub onto the bundle. It will happen in 5% of cases, but you have to be careful. So I don't think it's recommended to do it at this age unless there are some compelling reasons.
Sir,
If it is necessary to close, then surgery. If it is
If it is
necessary.
not suitable for a device,
But
then
it
I
is
would.
suitable.
It's
All
suitable.
rims are there,
So if
but
the-
one in only 6 months age, 11 kg. If it is suitable for the rims, but needed to be fixed, so we should go for surgery.
I would have a conversation with the family. I would say, listen, this can be done with the device, and there are people who do it with the device, but there is a slight risk of complications. And if you want to avoid that and your surgical results are excellent, I would opt for surgery.
Okay, sir. Madam, do you?
Why, sir, the rims are adequate, 11 kg weight? Why should I go for surgery? Either I should adopt the intervention procedure, or I should advise a patient to come later one, because this is suitable for intervention. We need not go for surgery. What I think.
So I would definitely, that's what the first question was. If the patient can wait, I would wait till the age of 3 years and we would do an intervention. But what Somaira asked me then was, if the patient is significantly symptomatic, what do you do?
And sometimes,
And you want a solution at that point.
Sir, at this point, I just like to interrupt you. If patient is symptomatic, I shall give the patient digoxin, diuretics, if necessary, AC inhibitor. I think there is no need of doing surgery in this patient. If patient is symptomatic, for the symptoms, I shall give the treatment and wait for the time for intervention. Why should I go for
I would not negate. I'm not against intervention. I'm not for surgery. But I would have to present a balanced perspective to the parents. You can't claim that the intervention is going to be 100% safe. If you look at all literature, the incidence of complications is the highest in very young children. 11, I have done several, actually 11, 8, lots I've done. But you do have to communicate to the family that there is a slight incremental risk and these are the options available.
thank you, sir.
You are right, sir, Sumatra. You are right, sir. But I think that there is no need of surgery in this patient. If we don't have to interfere at this moment, then we advise the patient to wait for the suitable time and then
Yes.
do the intervention. Because this ASD will not undergo spontaneous closure, that is the thing.
Yes,
We
sir.
have to do the intervention.
Yes, sir. Thank you, sir. Sir, our concern was sometimes we are compelled because the parents are so much anxious that this hole will enlarge or will it spontaneously close or what will it do? This is the frequently asked question in the OPD when I are seeing this 1.5 year and 2 years old with a large symptomatic ASD.
I think it is a very live conversation, but we have to move on
Yeah.
because